Great. So hi, everyone. Good afternoon. I'm Andrew Wiese, and I'll be presenting on behalf of Vice MPRINT Project 2. Sorry. If I can get this, I see here. Perfect. Great. And so Project 2 is focused on leveraging data science to understand outcomes for mothers and children affected by opioids. So to level set, right, so there's this national crisis of a growing burden of opioid-related diagnoses in pregnancy in the US over the last 10 to 15 years. And so this is prior work by Harai et al., in which they found that this growing burden is obviously different state by state, so there are some states where it's higher. But if we look at the change in prevalence over time, we've seen an increase across every state, right? So it's this recognition that this is a national crisis. And this growing burden of opioid-related diagnoses has severe consequences, right? So we also see this growing burden of pregnancy-associated drug overdose mortality. And so this is more recent work looking through 2020, in which we're seeing an increase in pregnancy-associated drug overdose mortality. And on that top figure, we can see that the substance most attributable to that increase in drug overdose mortality is from fentanyl and other synthetic opioids. What we also know is the timing of that increase in pregnancy-associated drug overdose mortality is happening both in pregnancy and in the late postpartum period. So this is something we're seeing an increased mortality both in pregnancy and after delivery in these individuals. Okay. Unfortunately, the consequences of these exposures are not limited to just the infant, or not limited to just the mom, but they can also impact the infant. And so one of the primary infant outcomes that we've been concerned of related to this crisis is the increasing prevalence of neonatal opioid withdrawal syndrome, or NOWS. Okay, and the reason we're concerned about NOWS is in this same time frame, we're seeing an increase in diagnoses for NOWS among infants as well. Okay, now the good news amongst this national crisis, and part of what Project 2 has helped provide the good news about, is that we do have medications that have been shown to be effective for the treatment of opioid use disorder during pregnancy. And so both buprenorphine and methadone are currently recommended to treat opioid use disorder in pregnancy. And so we know, particularly from some of our studies, that the use of these medications is associated with a decreased risk of overdose death, a decreased risk of relapse, and a decreased risk of hepatitis C and HIV infections among the mother. We also know that those pregnancies are more likely to go to term, and that infants are more likely to be born at a higher birth weight. However, there is this well-recognized risk that babies exposed to buprenorphine and methadone do have this increased risk of newborn drug withdrawal. And so that's really the space that Project 2 is operating in, is to try to better understand the benefits and the trade-offs in the use of these medications to treat opioid use disorder in pregnancy. And so the overarching objective of Project 2 was to test the hypothesis that maternal use of medications for OUD improves both birth outcomes and dyadic outcomes up to 1 year after birth. So work that we've presented at prior annual meetings in AIM-1 was really around developing and validating an algorithm to be able to identify opioid-exposed infants and opioid-exposed dyads from electronic health record and claims data. AIM-2, which we've also presented on, but I'll touch on briefly in some of our updated findings, is we really wanted to look at the impact of treatment with medications for opioid use disorder on outcomes proximal to delivery. So delivery outcomes for the pregnant mother, as well as birth outcomes for the infant. And then in AIM-3, work that's ongoing is we wanted to test the hypothesis that medications for opioid use disorder can also lead to improved dyadic outcomes up to 1 year after delivery for both mom and the baby. And so we'll get into those as we move forward. So AIM-1, this was a paper that we presented previously, so I won't go into too much detail. But in brief, what we were able to do is we were able to develop and validate an algorithm to identify opioid-exposed infants from the electronic health record. We had a PPV of over 95%, and so we feel confident that we can use this algorithm to identify these infants from the electronic health record. And that algorithm is published and currently available on PheKB if anyone's interested in applying it to their own EHR or data set. Then in AIM-2, again, where we're focused very much on those outcomes very proximal to delivery, our very talented medical student, Sunaya, led this paper that was published last year in JAMA Health Forum. And so this was actually not using just electronic health record, but it's using a data set that we have here at Vanderbilt, which is a unique linked data resource that includes Medicaid enrollment, pharmacy, and utilization data that we've linked to vital, to birth and death certificates, as well as to an all-payer hospital discharge database. And so what we're able to do using that data is to identify a cohort of dyads, of mom-baby dyads, that we can look for pregnancy exposures and maternal and infant outcomes after delivery. And so in this data set that includes data from 2010 to 2021, we have around, I think, 330,000 dyads. And so among that group, what we identified is a little over 14,000 dyads for which the pregnant mother had a diagnosis of OUD during pregnancy. And then what we wanted to do in this study was to compare the ever use of buprenorphine during pregnancy versus the never use of buprenorphine in pregnancy. And so what we found is a little over half of our population during this study period did have some buprenorphine exposure. And what we found is that when we looked at any adverse pregnancy outcome, either for the mom or for the baby, that we saw this protective effect of buprenorphine exposure compared to non-exposure. Further, when we looked at specific outcomes among just the mom or among just the baby, we saw protective effects across the board. And in fact, the most marked decrease was for preterm birth. So we saw this 35% reduction in the predicted probability of experiencing preterm birth in the buprenorphine exposure group compared to the non-exposure group. Okay. I think that's something we've presented previously. A new study that we haven't talked about that was recently published this year is also trying to look at this impact of MOUD, but also polysubstance exposure very proximal to delivery, and an outcome proximal to delivery, which is neonatal weight loss. And so in this study led by Nicole Anderson, a talented MPH student who now works at the Department of Health, she looked at the association of polysubstance exposure and neonatal weight loss among opioid-exposed infants. And so what she found in that study, and what she was specifically looking at, was the difference in maximum percentage weight loss for different polysubstance exposures among opioid-exposed infants. So the idea was, if we wanted to see if there was greater weight loss associated with specific individual polysubstance exposures. And so some of the ones we looked at were SSRIs, benzodiazepines, gabapentin, other antipsychotics, MOUD, as well as toxicology for opioids and non-opioids. And so what we found in sort of our combined analysis, in which we are looking at having any evidence of one of these exposures compared to none, we did not see a significant effect on the difference in maximum percentage weight loss. However, in some of the individual substance analyses, like medications for opioid use disorder and having a positive toxicology for non-opioids, we did see that having that particular substance exposure proximal to delivery was associated with a greater maximum percentage weight loss compared to their birth weight. Okay, and so that's something that we just want providers and clinicians who are taking care of these infants to be aware of, that there is this possibility of increased weight loss associated with these particular exposures. However, I think the good news, the good news that we found in this population, though, is we also calculated median weight trajectories for all of our infants, including by these individual exposures. So effectively looked at their percentage change in weight from birth weight through up to 14 days after delivery. And what we did find is that the majority of infants across all of these groups were able to meet the WHO recommendation to be back at their birth weight by day 14. So in spite of this greater maximum percentage weight loss, they are able to get back to birth weight by day 14 in this population. Okay, so some next steps and some ongoing work around this AIM-2 question. Related to that JAMA Health Forum paper, we're currently finalizing a paper, hopefully soon to be sent out shortly, comparing outcomes specifically among opioid-exposed infants with and without a NOWS diagnosis. So as I mentioned earlier, not every opioid-exposed infant develops NOWS, and so we want to look at outcomes among those with and without NOWS. The other interesting study is we have another medical student who is characterizing the impact of policy changes in our Tennessee Medicaid system on the uptake of different buprenorphine dosing regimens among pregnant mothers with OUD. And so the two policy changes we're most interested in that we know have happened in our Tennessee Medicaid system is that they've lowered some of the prior authorization requirements as well as increased dosing limits for the use of buprenorphine during pregnancy. And so related to NAME2, we want to expand that study to also look to see whether those policy changes might have impacted delivery outcomes as well. Okay. And so then in AIM-3, the idea here is we wanted to expand beyond just outcomes proximal to delivery. We wanted to be able to look at dyadic outcomes up to 1 year after delivery. But the other thing we wanted to do is to try to come at this project with a little bit more of a rigorous approach, that instead of just looking at ever use versus non-use, that we might want to be able to try to account for the more granular initiation of buprenorphine during pregnancy. We know that that timing might be important, and so we wanted to have an aim in which we could try to tease apart that effect as well. And so the method we are currently employing to examine that aim is to use a target trial emulation framework to examine the impact of initiating buprenorphine treatment on 1 year dyadic instability. So for those of you who may not have heard that term before, for a target trial emulation framework, it's really a mindset in how to conduct rigorous and well-done observational data studies. And effectively what it involves is two primary steps. And so the first step is that you can use an existing already in place randomized trial, but you can also come up with a hypothetical randomized trial for the causal question that you're most interested in. Okay, and then what you do is you outline how you would do that trial if you had all the money in the world and if you didn't have ethical concerns. How would you do that study? The second step is to then describe very specifically how you plan to emulate each of those above components using your observational data. Okay, and so what this framework and this way of thinking allows you to do is to be very explicit about the assumptions of your observational study design, so that you can try to avoid the common biases that we know affect many observational studies attempting to examine treatment effects. And so that's what we're currently doing in AIM-3. And so what we started with is outlining a hypothetical target trial for how we might examine the initiation of buprenorphine versus not initiating buprenorphine to examine the outcomes on dyadic instability. And so in this target trial, the way we might think about setting it up is that we would enroll patients from 2010 to 2021. We would enroll women 15 to 45 years of age anytime during their pregnancy at which they are identified with evidence of opioid use disorder. Okay? Now the wrinkle in this target trial that we might allow for is that we might be able to enroll patients at different time points during pregnancy and at different time points at which we identify their opioid use disorder diagnosis, right? And so because of that staggered design that we might allow for in our target trial, we wanted to have an observational design that also allowed for that staggered entry into the study. And so that's why we're doing our target trial emulation using something called a prevalent new user design, which I'll introduce and walk through in a few slides, okay? But going back to that target trial emulation framework, right, what we would do in our target trial is we would enroll patients, and then we would randomize them to either initiate buprenorphine or not initiate buprenorphine, right? And then at randomization is when we would start follow-up to look for the occurrence of the outcome. So the way that we are proposing that to emulate that in our study is obviously we can't randomize to treatment, but what we can do is we can assess their actual medication use using dispensing data that we have in our data source. And then what we can do for assignment is use that observed treatment and match on time conditional propensity scores as a way to control for confounding, as a way to try to approximate the randomization that you would get in a target trial, right? And then what we do, because in the study design that I'm going to introduce here shortly, we're matching buprenorphine initiators to non-initiators. Follow-up in our observational study starts on that match date, okay? So going back to this prevalent new user design, I actually don't like the name of it. So it was a design that was developed for the study of the prevalent use of medications, but it's been expanded to be able to ask a lot of other different questions, and so that's how we're using it in our particular study. And so there's a few steps to this prevalent new user design that we're currently implementing. And so the first step is that we're identifying a base cohort of pregnant mothers on the earliest date that we see that they have a diagnosis of OUD. So on that date, they enter our base cohort. What we then do in our base cohort is we look to see who initiated buprenorphine, right? So we look to see in our medication dispensing data who had a period without any buprenorphine use, who then filled a prescription, that is an indication that they have initiated buprenorphine. What we then do for each buprenorphine initiator is we identify all potential non-users in a time-conditional matching set who have a non-buprenorphine prescription at the same time point in the base cohort. And what that allows us to do is it allows us to match on time in the pregnancy. So the gestational weeks of the pregnancy. It allows us to match on their time since base cohort entry, so the time since we've identified them in our data. It allows us to match on calendar time to make sure that we're not comparing an initiator in 2021 to 2010, for example. And it also allows us to match on the number of prior prescriptions that we can see while they're in the base cohort as a way to control for their underlying healthcare utilization, okay? And then what we do is we match non-users from this risk set using the closest time conditional propensity score within the risk set, which we calculated using covariates measured in the prior 365 days. So moving to the figure, I've given you 3 examples of what this might look like, right? So in example 1, our buprenorphine initiator is the yellow diamond. And so this might be an individual who, the moment we identify them in our base cohort with OUD, we see that they initiate buprenorphine. What we want to make sure we do is we identify a comparable non-user at that same time point in the base cohort. So this would be an individual who, at that same time point, did not fill buprenorphine, but did fill a non-buprenorphine prescription, right? Example 2 is someone who maybe we identify them in the base cohort, they have no medication use for, let's say, 8 weeks, and then we see that they initiate bupe. Okay, what we want to do is when we identify our match control, we want to pick somebody similar who we identified with OUD, who filled a non-bupe prescription about 8 to 10 weeks later, and then we can match those individuals. And similarly, that's what we're doing in example 3, is someone who maybe initiated bupe later, but did have some evidence of filling prescriptions in the interim, right? And so what we assume that this design is allowing us to do is it is helping us account for that staggered initiation of buprenorphine throughout pregnancy. An important thing that it's allowing us to do is anchor our follow-up in our matched pair at the timing of the match, right? So when we get to the analytic stage, our buprenorphine initiator and non-initiator start follow-up at the same time for when we start looking for outcomes. And then the final thing that allows us to do is, because we're using those time conditional propensity scores, it's ensuring that our non-user is someone who had an equal predicted probability of initiating buprenorphine, but who didn't. Okay. That. And so unfortunately, I don't have any preliminary results of the actual effect on dyadic instability, but I do have some results showing how our matching process is working. And so what we found so far is that we identified 1,367 buprenorphine initiators who we were able to match to 1,367 non-initiators. Now you'll notice that this number went down from some of our prior studies, and that's because for this particular study, we're looking purely at individuals who are initiating buprenorphine during pregnancy. So some of our prior work might have included individuals who were on stable bupe therapy before pregnancy and then who maintained it. So in this particular study, we're very focused on that question of initiation. But what you can see here is that, so these numbers are relative to delivery, and so what this tells us is The mean initiation of buprenorphine is happening about 193 days before delivery, with a slightly higher median, and then you can see the range. And the similar numbers in our non-bup group tells us that we're able to identify that non-user group at a comparable time point. Okay, and then when we look within our matching process, when we look at the difference in the propensity score in our matched pairs, we can see that they're very closely grouped to 0, which is telling us that within our matched pairs, we're able to successfully find non-buprenorphine users who match well to the buprenorphine users. Okay. And so again, we do have preliminary results soon. I do want to comment, so I've been using the term dyadic instability. I probably should have introduced that a little bit earlier. So the idea here is for this study, the outcome that we're interested in, we have this all-encompassing term that we're calling dyadic instability. Ultimately, the way we're measuring that is whether the mom or the infant has any evidence of an ICU stay up to 1 year after delivery. We're measuring whether or not the mom or the baby die up to 1 year after delivery. And then with our Medicaid enrollment data, we can identify whether or not the infant was placed in foster care. And so that's the other piece of this, is whether the infant is placed in foster care. And so the reason we're focusing on these outcomes is these are severe, clinically meaningful consequences that would lead to a disruption of that mom-baby dyad. Okay? And then again, for this particular study, because we're focused on initiation and we're not accounting for adherence and use beyond that, we are looking for that intent to treat effect in this first study. Okay? So we do have some next steps in AIM-3. So the first is to finalize this study, looking at the intent to treat effect of buprenorphine initiation. I think an important part of this study that we're going to build in is to look at not only the intention to treat effect, but also to look at that per protocol effect. So to make sure that we are looking at people who stayed on therapy to look at the effect of that. The other next sort of target trial emulation that we plan to implement is to move a little bit beyond the use versus non-use, and to look specifically within those who do initiate buprenorphine. So there's this question of what is the best starting dose? What is the best dose to keep these pregnant mothers on during pregnancy? And so that's one of our next steps, is to use this design to compare different buprenorphine dosing regimens and to see how those impact dyadic instability. And then long term, what we want to take advantage of with our data is in some other projects that we have that use this data resource, we've been able to link it to developmental and educational data. And so we think there's an opportunity to further look at the impact of these medications on those longer term outcomes for the infant. Okay. So obviously we're holding questions at the end. Thank you for your time. I think I'm handing back off to you, Prince. Or no, to Wei Chi, yep.